Hello, it's my great pleasure and privilege to be here, despite virtually, to share our research work with all of you. My topic today is COVID-19. Over the last year and a half, the entire world has suffered from this pandemic. When it broke out early last year, I was spending my sabbatical year in New York City and witnessed some suffering and misery in my own eyes. It didn't take us long to decide that we should study the pandemic and use this analysis to inform the central research agenda of cultural psychology. Of course, this effort could enable us to make some contributions to the worldwide fight against COVID-19. One thing that captured our attention was how poorly the United States coped with the pandemic, especially in the first year of the pandemic, before vaccines became readily available. In January 2020, 96 million people had been infected with COVID-19 worldwide. Out of this, approximately 25%, 24.7 million were Americans. Also, around that time, 2 million people had died of COVID over the world. Again, about 20% of them, that is 0.4 million, were Americans. The United States is a big country for sure, but Americans' share in the world population is only 4.25%. So the United States failed, and it did so rather miserably. Why can that be? At the outset, I want to be clear that this man didn't help much. The absence of effective leadership is a major culprit. Early in the pandemic, an editorial of the New England Journal of Medicine, a premier medical journal in the US, said this: COVID-19 has created a crisis throughout the world. This crisis has produced a test of leadership. When it comes to the response to the largest public health crisis of our time, our current political leaders have demonstrated that they are dangerously incompetent. I agree, for sure. However, this political leadership had been elected some years earlier. And it is also the case that substantial proportion of the population, possibly up to 30 or 40%, still supported this leadership even after the pandemic went on, until this support eroded somewhat after the riot at the Capitol Hill in Washington, D.C. on January the 6th, very early this year. So the problem can be deeper, and there may be cultural, socioeconomic, and race-related root causes of the exceptional suffering of the United States and the people here. I believe that addressing this question goes beyond the US. To understand why US might have failed may help us shed new light on what we have to do to prepare ourselves for future pandemic. I propose that there are 4 critical factors in addition to the lack of effective leadership. First of all, historically, United States never instituted a universal mandatory BCG, vaccination against tuberculosis, that is likely to produce some immunity against many other respiratory diseases, including COVID-19. Social structurally, the United States is plagued with racism and enormous economic disparity. Culturally, Americans are rather peculiar in 2 ways. First, Americans are high in social openness, which is a trait I like, but which may also become a liability during a pandemic like the current one. Second, Americans are also highly individualistic. This aspect of culture may also have contributed to the failure of the US to cope with the pandemic. So let me start with this, BCG vaccination. BCG is a tuberculosis vaccination. It is quite effective at containing tuberculosis, a major killer in the 20th century. Importantly, however, as it turned out, several epidemiological studies have established that it is also effective in reducing the rate of death due to various respiratory infections. One experimental data shows that BCG initiates a series of genome-wide epigenetic changes, which in turn predict increased immunity against the experimentally administered virus. In the middle of the 20th century, many developing countries mandated BCG, including China, Japan, Portugal, Ireland. Interestingly, some countries, including the United States, never did so. Earlier this year, we compared countries that mandated BCG, countries that mandated it at one point but discontinued it before the year 2000, and those countries that never mandated it. Here, those are the examples of each of the three clusters of countries. In making a cross-national comparison like this, one big potential problem is that countries vary massively in the availability of diagnostic tests and diagnostic criteria in determining whether a given case or death is COVID-related or not. And also, there are a whole bunch of other confounds. One example is shown here, access to hospitals. These confounds can easily bias the total number of cases and deaths. However, these factors are unlikely to vary systematically within a fairly short period, say over a few weeks. Therefore, if we assess the rate of increase rather than the total number of cases or deaths, we may be able to ensure that these confounds are very unlikely to contaminate our results. And for this reason, in our research, we have looked at the speed of increase of infected cases, confirmed cases, and death in a very early period, initial 30 days of country-wide outbreaks. That is, day one is set on the day where 100 confirmed cases had been identified or one death was identified. Here's a paper we did, and this paper report what we found. And here's a result of the increase of daily rate, increase of daily cases in the first 30 days of country-wide outbreaks. The rate is significantly slower here, shown in blue line, in countries that mandated BCG all the time, compared to those countries that mandated it but discontinued it before the year 2000, and those countries that never mandated it. This graph shows plot the rate of exponential growth of infection in confirmed cases as a function of universal BCG policy status. And as you can see, if BCG was mandated throughout, the rate of increase in the first 30 days of the outbreak is much lower, significantly lower for sure, compared to other two types of countries, and the United States is here. The same results occurred when we analyzed the number of deaths instead of number of confirmed cases, and the results are nearly identical. Now, next factor I want to discuss relate to American exceptionalism. Many things are exceptional in the United States. In fact, some Americans do take pride in American exceptionalism. Some exceptional things in the US are really remarkable. For example, here, this is a remarkable achievement. However, many others are not very good, and in fact, horrible. One prime example in this category is racism, extremely harsh, malignant form of systemic racism. And other factor that's related to it is an excessive degree exceptional degree of economic disparity. Now, during the pandemic, these social structural factors could be very lethal. One key aspect of systemic racism can be found here, racial residential segregation. So here's a map of Chicago. In southern part of the city, segregate African Americans quite a bit. Here's the African American area, and the remaining area is relatively low in the proportion of Black people. And this is not unique to Chicago. In big metropolitan areas in the United States, people end up living in different parts of the areas depending on their racial status. Areas occupied primarily by racial minorities, including Blacks and Hispanics, tend to be very poor because there's a massive wealth disparity across racial groups in the United States. So these areas, minority areas, have much less social health related resources. For example, housing may be congested, medical services may be less accessible, and healthy food may be hard to get. Therefore, it is very likely that metropolitan areas, big city areas in the United States, which are racially segregated, may be more vulnerable to COVID-19. And in addition to this, some metropolitan areas, and particularly some areas within the metropolitan areas, say counties, are just not only segregated, but also economically unequal. And economic inequality can exacerbate the effect of residential segregation because the poor and under-equipped areas may fare even worse if there's a greater economic disparity. We recently carried out an analysis of the speed of the increase of COVID-related death and infections in the US's 100 largest metropolitan areas. Here's a paper that reports the results. All the areas in the United States are racially segregated, but some, such as Detroit and New York City, are more so than some others, such as Salt Lake City and Seattle. Also, some countries, including some counties included in these areas, show greater income inequality than some other counties. Here's what we found when we used the measure of segregation between white people and Black people. As you can see, the increase of death in the first 30 days, this is increase of cases, confirmed cases, in the first 30 days of county-wide outbreak was much faster, as shown in steeper slope, in counties which are located in highly segregated metropolitan areas, also of which are high in economic disparity. Same result is visible, is very evident when segregation was defined by Hispanic and white line. Interestingly, the same was not true when a measure of segregation between Asians and white are used. This probably is due to the fact that even though Asian Americans suffer from racism, they still do much better economically compared to Blacks and Hispanics. So let me stop here and address questions you might have so far. So far, I have discussed two factors that might explain why the United States did so poorly during the pandemic. I now want to turn to two additional factors, which are more directly linked to American culture. First, American culture is very high in social openness. People are very open, easy to get along with. They choose their friends. They also find it very easy to have social relations. Of course, they also find it as easy to get rid of relations they no longer like. This cultural or social ecological trait is called relational mobility. During the pandemic, this can be a liability. The virus spread by social contact, and social openness lends itself to social contact with a wide range of people, namely strangers. In yet another recent study, we adapted a countrywide scores of relational mobility. Here's a paper reporting the result from this work. Based on early work by Yuki, Thompson, and others, countrywide scores of relational mobility are available. This index assesses the extent to which people in a given region, say country or territory, think people in their own community freely choose relationship partners and interact freely with others they like. Using this index, we showed the spread of COVID-19 is faster in countries with higher relational mobility scores. Here's a regression line predicting the number of confirmed cases as a function of the days during the first 30 days period of countrywide outbreaks. As you can see, the slope is steeper in countries that are high rather than low in relational mobility. Here's a plot of regression coefficient as a function of relational mobility. As you can see, the United States is very high in relational mobility, and as you can expect, it also shows a very high rate of spread of COVID-19 related cases. Now, we got the same finding when we analyze the number of deaths as a function of relational mobility. As a function of the days initially, and then plot the rate of increase of daily death as a function of relational mobility, and you can find the same effect. Another major factor that is relevant here is individualism. Individualism refers to the tendency to be more concerned with one's own needs, goals, and interests than with group-oriented concern. It is linked to a view of the self as independent. Individualism is often seen as opposite of collectivism, which involves the tendency to be more concerned with groups' need, goals, and interests than with individualistic oriented interests and is linked to a view of the self as interdependent. Several country-level scores of individualism and collectivism are available, and they are highly correlated. And if you use those scores, Americans come out as very high in individualism. Now, you might wonder how individualism and relational mobility may be related. In fact, those two constructs are highly correlated in positive direction, but they are very distinct. Countries placing high value on individualism may encourage individual choices in social relations, thereby breeding high relational mobility. However, countries placing a high value on collectivism may also encourage social interactions with a wide range of people under some conditions. For example, if such interactions meet the collective interest. For example, Latin Americans are high in collectivistic value at the level of family and close in-group, and yet they are very socially open outside of it. One reason could be that Latin culture has a strong root in commerce and other related activities, which would require interactions with the strangers to benefit their immediate in-groups. It is also important to note that in the Berg et al. Study that looked at the effects of universal BCG policy, we found no evidence that country-level individualism or collectivism predict the growth rate of confirmed cases or death during the first 30 days of outbreaks. So this cultural variable does not affect people's susceptibility to virus during a very early period of the pandemic. However, it could still influence behaviors that promote the collective good by reducing the infection risks of the community as a whole. One case in point is mask wearing. At the individual level, it can be an annoyance, especially in cultures that value self-expression, one very important facet of individualism. Mouth is a major medium by which to express the self. Therefore, covering it up could be antagonistic to the ideology of individualism. The adverse reaction to mask wearing can therefore be rather strong in contemporary mainstream American culture. Indeed, many Americans seem to have maximized their psychological welfare by not covering their mouth. This behavior, however, has come at a grave cost for the collective. Each individual is protected as long as many others in the community wear masks. If a majority choose not to wear a mask, then you may not be protected even if you wear a mask. Unfortunately, again and again, many Americans seem to have prioritized their personal convenience or preference while ignoring collective consequences of doing so. In a recent study, Liu and colleagues show that individualism or collectivism is in fact related to mask wearing. These researchers analyzed responses to the question, how often do you wear a mask in public when you expect to be within 6 feet of another person? The data were available in all United States, even though US as a whole is highly individualistic, its states substantially vary on this dimension. For example, southern states such as Louisiana and Georgia are high in collectivism, and yet Western states such as Colorado and Wyoming are high in individualism. One important exception is California and Hawaii, which are low in individualism or high in collectivism. The reason is that these states have higher proportions of Asians and Hispanics who are known to be collectivistic. Here's a plot of mask wearing as a function of state-level individualism and collectivism. As you can see, mask wearing is more common in states which are high in collectivism and less common in those states are high in individualism. Liu et al. Shows that replicated this pattern cross-culturally by using cross-cultural data. More collectivistic cultures or countries tends to have higher proportion of people who are wearing masks as compared to more individualistic cultures. And of course, America is one of those countries which are very high in individualism. Now, this brings me back to the first study I discussed today. There, we showed that the universal BCG policies are effective in containing the initial impact of COVID-19. One point I didn't say is that such policies are more likely in collectivistic countries than in individualistic countries. Vaccination is another pro-social behavior that benefits the collective good, even though it can be an annoyance and even a potential health risk at the individual level. Therefore, from this perspective, the BCG study may be used to support the contention that collectivism is an adaptation for group survival at the expense of individual freedom and liberty. As such, this cultural ideology seemed to have done what it was supposed to, namely to protect the group while containing individual freedom. Now, let me get back to my original question. Why did the United States do so poorly in the first year of the pandemic before vaccines became available? In this talk, I highlighted three facets of historical, social, and cultural dynamics involved in the coping with infectious diseases, including COVID-19. In all the three facets, Americans appear handicapped relative to many other peoples, including Asians. This might explain why the US and other countries culturally close to it, including many Western European countries, did so badly during the current pandemic, especially in comparison to most Asian countries when vaccine had not been available. The 20th century is said to be the era of infectious disease. Due to industrialization, the physical distance between humans and wild animals is decreasing dramatically, so it may become increasingly frequent for infectious viruses of wild animal origin to spill over to humans. Furthermore, due to globalization, the viruses spilled over can travel worldwide so readily and so fast. We are currently witnessing the deadly consequences of this combination of industrialization and globalization. The work I discussed today can broaden the psychological science in general and cultural psychology in particular by encompassing cultural, social, structural, and racial factors as crucial anchors in understanding human psychology. It bears an emphasis that understanding infectious disease in all aspects, including people's reactions and coping with it, is highly practical. So it is quite apt to close my talk by quoting Kurt Lewin, one of the founders of social psychology, who observed, "Nothing is more practical than good theories." This dialectic between basic and applied research, he suggests, is going to enrich both science and society. Also, just as important, it is very crucial to reaffirm the positive role of science in policies and decision-making at every level, from local to state to national and all the way up to international. I hope my discussion today is enough to persuade you that systematic psychological inquiry on the pandemic can shed some ray of light even in the darkest time. So thank you very much. The work I discussed today is fully collaborative in my lab, and I thank all of them. And here's Martha Berg, Christina Salvador, Irene Malani, and Chinkyang Yu, who are particularly active in carrying out the research I discussed today. And finally, I appreciate the funding sources for the research I discussed. So thank you very much, and I welcome questions.